جزء منها تعرضنا له في المحاضرة بتاعت الصبح، وفي أجزاء تانية مش هنتعرض لها أساسا في الكورس، زي الإيميجينج أوف ذا سيلا وبعض الحاجات التانية اللي هي فيها أساسا كمية ضخمة جدا من التيومرز في هذا المكان. ولكن إحنا في مصر عندنا البيدياتريك ايميجينج فرع من فروع الأشعة، بالرغم إن هو داخل في كل الفروع التانية، لكن إحنا بنحاول نفصل البيدياتريك ايميجينج لوحده ونخلي كل الحاجات اللي بتتعلق بالبيدياتريك موجودة فيه. وده الحقيقة بيكرر بعض الحاجات اللي ممكن تبقى موجودة في الأدلتس. من البيدياتريك انتراكرينيال انفكشن تقريبا شبه الأدلت قريب قوي. انتراكرينيال تيومرز جزء منها داخل في الكلام عن الأدلتس، ولكن دايما احنا بندرس البيدياتريك في الآخر خالص، فبيبقى زي ملخص كده عام على الايميجينج. وفي نفس الوقت بنتك قوي ونركز على الحاجات specific for the pediatric age group. فالبيدياتريك تيومرز محطوطين تحت سب ايتمز كتار قوي، اللي هم نابوسيل فوسا تيومرز. على اساس معظم الحاجات بتاعت البيدياتريك بتطلع عند نابوسيل فوسا. supratentorial tumors, intraventricular, supracellular, biennial body, congenital tumors, and the cystic lesions اللي هم يعتبروا جزء من tumor like. Then we start by the posterior fossa tumors, and you remember we have mentioned this morning something about the ependymoma, the medulloblastoma, the primitive neuroepithelial tumor, the brainstem glioma, the pilocytic astrocytoma, the hemangioblastoma, and the trigeminal neuroma. We did mention something about this, and we'll do now. Then, starting by the ependymoma, and you have already seen so many cases, and this is one of the common pediatric lesions, which is seen mainly in the posterior fossa, midline in position in relation to the false ventricle. And you remember that the prognosis of the posterior fossa lesion is the worst, and the best of them is the ependymoma of the phylum terminal. Then this is the ependymoma, which contains calcium in about 40 to 50% of the lesions, and it is considered the most common midline posterior fossa tumor containing calcium. And this tumor also shows the cystic changes, as I have said this morning, and it has high incidence of seeding or spread via the CSF. And you remember this figure with extension of the tumor through the exit foramina of the fourth ventricle, and also you remember this appearance of a tumor with a CSF seeding in the basal cisterns as well as in the supracellular cistern. And the ependymoma is like any other tumor, will show low signal in the T1 and high signal in the T2, with almost homogeneous or heterogeneous post-contrast enhancement, regardless the presence of calcium and the vessels. The primitive neuroectodermal tumor are a group of the tumors which cannot be differentiated histologically, and they include the medulloblastoma, the retinoblastoma, ependymoblastoma, medulloepithelioma, and the cerebellar neuroblastoma. These tumors cannot be identified through the histology apart from being of the primitive neuroectodermal type. And whenever they diagnose this, they say this appearance may be one of these tumors. And most of them الحقيقة ليهم يعني very bad prognosis. And you remember the primitive neuroectodermal tumor can be diagnosed on the basis of homogeneous enhancement and absence of cystic changes, as well as the absence of calcification and the presence of a tumor in the midline position. The medulloblastoma is the next tumor in the posterior fossa, which has too many features of the ependymoma. But the age group is usually younger than the ependymoma, and the incidence of calcium is more or less أقل من الإبنديموما. And you remember this medulloblastoma will arise from the roof of the fourth ventricle. So in the sagittal images, the ependymoma will fill the fourth ventricle, while the medulloblastoma will leave the upper part of the fourth ventricle unoccupied by the tumor. And this is sometimes helpful to differentiate considering the age and the presence of calcium. And if you look carefully for this lesion, which is medulloblastoma, and you can see this enhancement along the anterior wall of the brainstem and the enhancement along the borders of the spinal cord. And this is classic for CSF seeding for this kind of tumor, which is well known, one of the well-known tumors to produce CSF seeding. Then ependymoma versus the medulloblastoma, you remember the sagittal is the most helpful. And in the sagittal image, you can see the ependymoma almost filling the fourth ventricle and extending through the foramina. Medulloblastoma, good part of the tumor is present in the cerebellar hemisphere, and the other part of the tumor is present inside the fourth ventricle, and the upper part of the fourth ventricle is usually spared. Then this is the medulloblastoma showing the cystic component and the characteristic appearance in the sagittal image, with the main bulk of the tumor is in the cerebellum, part of the lesion in the fourth ventricle, and the upper part of the fourth ventricle is free. This is another case of medulloblastoma by CT and by MRI. And you see the tumor midline in location in the region of the fourth ventricle. It contains calcium. All these features are also good for the ependymoma. And this appearance is also typical for an ependymoma. But in the sagittal image, and you see this part of the fourth ventricle, which is not occupied by the tumor. This is one of the helpful landmarks to suggest the medulloblastoma, also considering the age. And the age of medulloblastoma is a little bit younger compared to the ependymoma. Then we came to the brainstem glioma, and you remember that one of the most important features of brainstem glioma is the exophytic extension into the prepontine system. And this is typical, and you see this extension and this extension on both sides of the basilar artery, and it ends by the tumor is anterior to the basilar artery, and the basilar artery is shifted posteriorly. Then one of the classic features also is the flattening of the anterior aspect of the fourth ventricle and the extension of the tumor through the middle cerebellar peduncle, invading the cerebellar hemisphere. And you know that the brainstem glioma, 50% of the lesions do not enhance, and they are usually of the diffuse type of the astrocytoma. But whenever they show any pattern of contrast enhancement, they are turned into the most severe one, which is the glioblastoma multiforme. And this is a good example by MRI, T1 weighted image, T2 and T1 post contrast, and you see the enhancement of the tumor and the classic exophytic extension of the lesion in the prepontine system. Then this is the brainstem glioma once more in T2 weighted image, in the FLAIR image, and in the diffusion weighted image, showing no evidence of diffusion restriction. Then the well-known posterior fossa tumor in the pediatric age group, which is the pilocytic astrocytoma, اللي هو عبارة عن cyst with an enhancing neural nodule. And you see this cystic lesion with an enhancing neural nodule, and you consider pilocytic astrocytoma whenever you see this appearance, whatever the size of the nodule compared to the size of the cyst. Then you see this appearance, and there is a cyst with a very big neural nodule in the posterior fossa. You consider pilocytic astrocytoma. And if you have the chance to see the vascularity of the nodule, then you may diagnose the other a lesion which is similar to this one, which is the hemangioblastoma. ولكن you know that the hemangioblastoma is a tumor of an adult, and the pilocytic astrocytoma is a tumor of the pediatric age group. And here you can see this cystic lesion with enhancing mural nodule, and the fourth ventricle is compressed with consequent supratentorial obstructive hydrocephalus. Another case of pilocytic astrocytoma, and you see this is the T1, this is the T2, and this is T1 post-contrast in a patient 12 years old. Then you diagnose pilocytic astrocytoma. Then hemangioblastoma is a tumor of an adult, but the von Hippel-Lindau syndrome can occur also in the pediatric age group. Then whenever you see a lesion like this, which is assist with an enhancing mural nodule, you consider pilocytic astrocytoma. If this is an adult patient, you consider the hemangioblastoma. But in this tumor, it is rare in the children, but can occur in children. أي حاجة ممكن تحصل زي ما احنا اتفقنا. And this is a cystic lesion with an enhancing mural nodule. Consider pilocytic astrocytoma in the pediatric age group, and consider hemangioblastoma in an adult. But remember that hemangioblastoma can also occur in the pediatric age group. And if you see a lesion like this, and you can confirm that the nodule is hypervascular, and it shows the tumor blush in the angiographic film, then you consider the possibility of hemangioblastoma. And you remember this example in a child, and this is typical for a pilocytic astrocytoma. ولكن this tumor has been removed and proved to be hemangioblastoma. And the von Hippel-Lindau syndrome is diagnosed based on the presence of one of three criteria: either multiple hemangioblastomas, or hemangioblastoma with a family history, or hemangioblastoma and visceral tumors. And you remember that the hemangioblastoma in the cyst may be very small, لدرجة إنك أنت you don't see the cystic part of the lesion, and you see only the nodule, which is almost filling the whole part of the cystic lesion. And one of the posterior fossa tumors that can occur at the cerebellopontine angle is the trigeminal neuroma. And you remember that the trigeminal nerve in the normal anatomy is coming from the brainstem into the cerebellopontine angle, then goes through the skull base into the paracellular area. And you remember also that the most common cerebellopontine homogeneously enhancing or enhancing lesion is the acoustic neuroma. And the second is the meningioma. Then when to diagnose the trigeminal neuroma? There are 4 situations for the diagnosis of the trigeminal neuroma. Number 1, and you see a tumor which is dumbbell shape or 8 configuration. Part of the tumor in the paracellular area and the part of the tumor in the cerebellopontine angle region. And this is because this is the course of the trigeminal nerve through the basal skull foramina. And this is the paracellular component, and this is the cerebellopontine component. And trigeminal neuroma is considered one of 4 common lesions occurring in the paracellular area, which are number 1, the meningioma, number 2, the trigeminal neuroma, number 3, the chordoma, and number 4 is the carotid cavernous fistula. All these lesions are homogeneously enhanced in the paracellular area, and there are certain signs to differentiate all these tumors from each other. You know that the ganglion of the trigeminal nerve is called the Gisserian ganglion, and the Gisserian ganglion is present in the Meckel's cave, which is posterior to the cavernous sinus. Then, if you look to the cavernous sinus containing the internal carotid artery, and you see a non-enhancing lesion here, and this is the Gisserian ganglion, which is located in the Meckel's cave, posterior to the cavernous sinus. And one of the criteria of trigeminal neuroma is the disappearance of the shadow of the Gisserian ganglion on the same side of the lesion. That is to say, this tumor is originally arising from the nerve itself. But if you see a homogeneously enhanced lesion in the paracellular area, and you can clearly identify the Caesarean ganglion, then this tumor will not be of trigeminal nerve origin. It may be a meningioma or chordoma, for example. Then the dumbbell configuration is characteristic of the trigeminal neuroma in the paracellular area, and also the extension of the tumor through the skull base foramen. You see, this is a paracellular homogeneously enhanced lesion. And look here in the coronal image, the tumor is extending through the widened framing into the extracranial area. And this is the course of the trigeminal nerve outside the skull. And then you consider this lesion is of trigeminal nerve origin. Then the trigeminal neuroma appears as a dumbbell configuration, figure of 8, and it appears in the paracellular area with absence of the Caesarean ganglion, and it also appears in the paracellular area extending through the basal skull foramina extracranial. Then we came to the supratentorial lesions, and we will discuss the BXA, which is a tumor of the pediatric age group mainly, the glioblastoma multiforme, which occur in both age groups, the gliomatosis cerebri, metastasis, and the neurofibromatosis type 1. Then you remember this appearance, which is typical of BXA, and a cyst with an enhancing mural nodule, and the nodule is located in a superficial location. And the superficial location may be on the surface of the brain laterally or on the surface of the brain medially. And this is a classic appearance of a BXA or pilocytic sensoastrocytoma in a male patient 8 years old. And you see the cystic component, and you see the enhancing mural nodule, and the nodule is superficially located. Then the superficial location, as I have said, may be on the medial surface of the brain. And you can see that this nodule is also superficially located on the surface of the brain, the medial aspect of the cortex. And you see the cyst and the enhancing mural nodule. This is the CT scan without contrast injection, and you see the nodule, and you see the cystic component. And this is also a BXA, which is a lesion or a nodule, and the nodule has a more or less superficial location, and the cystic component is well seen, and the patient is 19 years old. Then the glioblastoma multiforme can occur in the pediatric age group and can occur in adults. The most diagnostic feature of glioblastoma multiforme is the presence of heterogeneous enhancement or marginal enhancement of non-uniform thickness. And this is an example, and this is another example, two different cases of glioblastoma multiforme. And this is a female patient, 42 years old, 24 years old, and you see a lesion which is of low signal in the T1, high signal in the T2, and some points of contrast enhancement. If you apply the rules we have said this morning, you may say that this is an aplastic astrocytoma. Yes, it may be so, and it may be also the glioblastoma multiforme. Whenever you can detect hemorrhage inside the tumor, this is glioblastoma, because the diffuse astrocytoma and the anaplastic astrocytoma do not contain hemorrhage or necrosis، ولكن اللي بيحتوي على الهemorrhage والنكروزس في الجليومز هو the glioblastoma multiforme. And this is a 16 years old male, and you see a big tumor in the splenium of the corpus callosum with heterogeneous enhancement after gadolinium injection, diagnostic of glioblastoma multiforme. And you remember the diffuse, the infiltrating glioma or the gliomatosis cerebri is a lesion that is not seen in the CT and not seen in the MRI T1 weighted image, but seen in the T2 and the FLAIR, and is usually not seen in the diffusion because it has free diffusion. Whenever you inject contrast material, the lesion does not enhance. And if you look carefully to the CT scan, you can see a mass effect exerted on the occipital horn of the ventricle, but you cannot see the tumor. And the MRI T2 weighted image, and you can see the tumor compressing the adjacent ventricle. And you remember this example, I showed it to you this morning, and the lesion is not seen in the T1, but seen in the T2 and the flare, and after contrast enhancement it does not enhance, and in the diffusion weighted image, you see some minimal restriction of the diffusion. Also remember this case, and here you cannot see the tumor, only a small focus of enhancement maybe, or this is blood actually, this is T1 without contrast, and this is T2, and after an injection of contrast you do not see any pattern of enhancement. Then the metastases in the pediatric age group are not always similar to the others, and usually the metastases here are either through the CSF or those of the neuroblastoma, which are selectively involving the sutures of the skull. Then if you see this case, and you see the suture is markedly widened here and there, and you see a mass which is centered to the suture, and there is another mass here and another mass here, and this appearance is typical for metastasis from neuroblastoma. And neuroblastoma metastases usually select the sutures, and they destroy the edges of the sutures and form a mass, which is partly intracranial and partly extracranial. Then you can also see metastases like adults, cover in the brain in some cases, but actually when I looked for some examples, I didn't find it easy to see metastases in the pediatric age group which are simulating those of adults. ولكن معظم الميتاستاسز اللي انا شفتها في الانترنت وفي الارشيف وكده كلها متركزه على السوتشرز of the skull. Then we came to the intraventricular tumors, and we have the two main intraventricular lesions, the ependymoma and the choroid plexus babyloma. And two other lesions, you remember this one, اللي هو the subependymal giant cell astrocytoma of tuberous sclerosis, and the central neurocytoma, which is a tumor between the pediatric and the adult age group. Then starting by the choroid plexus babyloma, this tumor arises from the choroid plexus. Then you expect that this tumor is a tumor secreting CSF, and the overproduction of CSF will result in marked dilatation of the ventricles, secondary to the overproduction of the CSF. This is usually the typical location of the tumor, centered to the site of the choroid plexus. And characteristically, the choroid plexus is very vascular structure. Then the tumor is also very vascular structure, and it usually contains areas of hemorrhage and necrosis. Actually, the surface of the tumor is almost similar to اللي انت شايفه دوت انتوا اسمه ايه عندكم التوت؟ توت؟ كويس ممتاز. وانت عارف الصبح انا قلت لك ان المكان دوت محبب قوي للانترافنتريكولار مننجيوم، ولكن في فروقات كتير جدا جدا ما بين الاثنين. من اشهرهم ان ده بتاع الاطفال والتاني بتاع الكبار، ان السيرفس دوت زي التوته، التاني اسمه سيرفس، ان دوت بيسكريت سي اس اف، المننجيوما do not secrete CSF. And you know that 85% of this tumor are present below the age of 5 years. يعني معظم these lesions occur in children younger than 5 years, and they always are associated with hydrocephalus due to overproduction of the CSF and the mechanical obstruction due to hemorrhage and obstruction of the CSF pathways. But you can see some choroid plexus babyloma which do not secrete CSF. Then you will see the tumor with no CSF overproduction inside the ventricle. Considering the age of the patient, you should suggest the possibility of choroid plexus babyloma if the lesion is located in a typical location, which is the site of the choroid plexus inside the lateral ventricle. Then this is a classic appearance of choroid plexus babyloma, which is similar to the surface of the mulberry or el tuta. And this tumor, although it is benign, it can spread with the CSF. although it is a benign lesion. Then you can diagnose it being in an age of the pediatric patient, and it is located inside the ventricle, mainly the region of the choroid in the lateral ventricle. Then you suspect the choroid plexus papilloma. And this is an example of the papilloma which does not secrete CSF. And you see the ventricles are not dilated, and the tumor surface is lobulated, and it is inside the ventricle. And another appearance of choroid plexus papilloma, and you see the region in the T1 and the T2 and in the T1 post contrast. And this surface is very characteristic of the choroid plexus papilloma, and also the site of the lesion in the lateral ventricle is also one of the criteria of this lesion. Then here is a patient with choroid plexus papilloma by CT and by MRI, and the sagittal image show the typical and the classical location of the tumor inside the ventricle. Then the giant cell astrocytoma is located in the frontal horn of the ventricle. It shows homogeneous pattern of enhancement. It should be present in a patient with tuberous sclerosis, and the main diagnostic issue for tuberous sclerosis is the presence of calcium in the ventricular wall. But remember that in patients with tuberous sclerosis who are younger than 6 months, the tubers are not yet calcified. Then you will see some tubers in the wall of the ventricle which are not calcified, and you also diagnose this as a giant cell subependymal astrocytoma. And this is another example. You see the calcium of tuberous sclerosis in the wall of the ventricle, and you see the tumor occupying the frontal horn of the ventricle, and it is homogeneously enhanced, diagnostic of giant cell subependymal astrocytoma. Another case of large subependymal giant cell astrocytoma in the pre-contrast and in the post-contrast CT scan. The tumor is present in the frontal horn, associated with the classic stigmata of tuberous sclerosis, which are subependymal calcification. After injection of contrast, you see homogeneous pattern of enhancement of the lesion. And here, by MRI, which is very weak in detection of calcium, you can see some indentations on the wall of the ventricle, and this represents the size of the tuber foci. And calcium in this case will appear somewhat bright in the T1 and black in the T2. And this is one of the appearances of calcium, as I will mention tomorrow, inshallah. And here you can see this is the tumor in the frontal horn of the ventricle, and we can see the tumor in the T2 weighted image. Then the central neurocytoma is one of the well-known intraventricular tumors. It is not exactly present in the pediatric age group, ولكنه موجود في سن حوالي 20 سنة. This is actually the age of the tumor. But due to variations, you may see the tumor in a younger age or even in an older age. In order to diagnose the central neurocytoma, you need only one finding, which is the presence of cystic component inside the tumor. This is the most suggestive criteria for this particular tumor. The tumor is heterogeneously enhanced, and it contains calcium, of course, and it contains cystic component in about 70% of cases. Then if you see a mass inside the ventricle, which has real cyst, not an area of breakdown, a real cystic component, then you think of a central neurocytoma. And if you look here carefully, then you can see these internal areas of cystic degeneration within the tumor in a patient who is 17 years old, which is around the age of the 20, then you suspect the possibility of central neurocytoma. And this is the classic appearance of the central neurocytoma with cystic component, which is better seen in these images, in the enhanced image and in the FLAIR image as well. And the cystic components are also seen here clearly in the T2 weighted image. Then the central neurocytoma is one of the intraventricular tumors occurring in midway between pediatric and adults. And the most helpful diagnostic criteria for this tumor is the presence of a cystic component. Then we came to the suprasellar area, and in the pediatric age group, we have 4 lesions occurring in the suprasellar area. These are the most common suprasellar tumors in the pediatric age group. Number 1, the craniopharyngioma. Number 2, the hypothalamic glioma. Number 3 is the hypothalamic hamartoma, which is also known as tubercinarium hamartoma, and the germinoma. Then the diagnosis of craniopharyngioma depends on 2 main issues. Number 1, the cystic component. Number 2, calcium. Then if you see a large cyst in the suprasellar area, which is containing calcium, and sometimes a mural nodule, which is enhancing, then you think of a craniopharyngioma. And this craniopharyngioma has 2 main peaks, one in the pediatric age group and one in adult age group. So it can be easily identified in pediatric patients. Like this one, you see a big cystic component and a nodule which is located in the suprasellar area. Then one may say, this is a pilocytic astrocytoma with an enhancing mural nodule. What do you say? Yeah. Number 1, the nodule is not inside the cyst. Number 2, the nodule in the pilocytic astrocytoma do not calcify. It is the wall of the cyst which can calcify in the pilocytic astrocytoma. Number 3, the pilocytic astrocytoma is located in the posterior fossa, not in the supratentorial area. Number 4, if you have different imaging planes, you will ensure that this lesion is outside the brain, I mean in the extraaxial location in the suprasellar system. Then this is a lesion which is predominantly located here in the midline above the cella with cystic component and a large calcified component, diagnostic of the craniopharyngioma. Then the neurofibromatosis type 1 is a collection of lesions which can affect the visual pathways. And you know that the visual pathways starts from the optic nerve, then the optic chiasm, then the optic tract, then the visual radiations in the occipital area. And if you see lesions along this course, then you think of neurofibromatosis type 1. Regardless, the lesions are gliomas or hamartomas. And you see like this, I will discuss the neurofibromatosis just now, but whenever you see a lesion in the suprasellar area and in the pediatric age group, then you think of a craniopharyngioma. In order to diagnose craniopharyngioma, you should have a cystic component and calcium. But if you have a lesion which is solid and homogeneously enhanced, then the diagnosis will be hypothalamic glioma. And hypothalamic glioma is an isodense suprasellar mass which shows a strong homogeneous enhancement and it does not contain calcium. In the coronal image, you see the tumor, and this is the stalk, and this is the pituitary gland. And this is the suprasellar mass in a child showing homogeneous enhancement containing no calcium, diagnostic of hypothalamic glioma. And this is hypothalamic glioma in the suprasellar area showing homogeneous enhancement above the cella in pediatric age group, diagnostic of hypothalamic glioma. And this is a male patient 10 years old. Then we see a lesion here in the suprasellar area. It is of low signal in the T1, high signal in the T2, almost homogeneous enhancement after injection of contrast. And this is the pituitary gland, and the lesion is above the pituitary. Then, considering the appearance of the lesion and the age of the patient, you know that this is a hypothalamic glioma. This is the difference between hypothalamic glioma and the craniopharyngioma. The hypothalamic glioma is a solid lesion, while the craniopharyngioma should have a cystic component. The hypothalamic glioma contains no calcium, while the craniopharyngioma, the calcium is essential for the diagnosis. The hypothalamic glioma is of low signal in the T1, while the cyst of the craniopharyngioma may contain motor oil fluid زي ما انتم عارفين، وبيبقى هاي سيجنال في تي 1 في بعض الأحيان. بعد كده الهايبوثالاميك جلايوما بتعمل هوموجينوس انهانسمنت أو شوية هيتروجينوس انهانسمنت، ولكن الكرينيوفارنجوما السوليد كومبوننت بس هو اللي بياخد صبغه، والسيست وول ممكن ياخد صبغه لكن السيست نفسه does not enhance. ده ليه علاقه جامده جدا بالنيوروفايبروماتوزس، وده ملوش علاقه خالص بالنيوروفايبروماتوزس. ايه هي النيوروفايبروماتوزس؟ زي ما احنا اتفقنا this is an autosomal dominant disorder and حوالي 50% من الناس عندهم positive family history, and there are multiple lesions along the visual pathways. starting من optic nerve ان يكون في optic nerve glioma، وبعدين دخلت على الكاز، وبعدين دخلت على التراكتس وهكذا. Then if you have an MRI which is more better than the CT for detection of these lesions, then you will see some lesions along the course of the visual pathways which are black in the T1 and bright in the T2. Then if you inject contrast material, you will see one of two things, either enhancement or no enhancement. If the lesions are enhanced, they are considered gliomas. If the lesions do not enhance, they are considered hamartomas. Then if you go back to this and you consider to differentiate hamartomas from gliomas, which are lesions extending along the visual pathways in patients with neurofibromatosis type 1, you inject contrast medium. If there is no enhancement and no mass effect, of course, and no edema, and these lesions are hamartomas. But if the lesions enhance, then you know that these lesions are gliomas. And the glioma may occur in the optic nerve. You remember the tortuosity of the optic nerve and the enlargement. This is bilateral optic nerve glioma, and the lesion has extended intracranially in the suprasellar area, forming another part of the glioma in the suprasellar area of the region of the hypothalamus. Then the hypothalamic glioma is one of the components of neurofibromatosis type 1. If the patient has other stigmata, زي ان هو يكون عنده optic nerve glioma او يكون عنده glioma along the visual pathways، ولكن ممكن الهايبوثالاميك glioma تبقى لوحدها بس اللي هي the tumor which is homogeneously enhanced in the suprasellar area, no cystic component, and occurring in the pediatric age group. And this is of course gliomas in the course of neurofibromatosis type 1. You see the visual pathways and the lesions in the pre-contrast are of low signal. After contrast enhancement, they enhance diagnostic of gliomas infiltrating the visual pathways in a patient with neurofibromatosis type 1. Then the last one occurring here is the tuber cinerem hamartoma. What is the tuber cinerem first? In the sagittal image, you see this is the pituitary gland, and this is the posterior pituitary, and this is the anterior pituitary. And here is the pituitary stalk. And if you follow the stalk, you will reach this cora, which is the mammillary body. The distance between the cora and the infundibular stalk is known as the tuber cinerem. And this tuber cinerem is the seat of a well-known, very characteristic lesion, which is located here. And you see this lesion, which is midway between the mammillary body and the infundibular stalk. This lesion is a spot diagnosis. It cannot be mistaken for any other pathology because of this feature, which is no enhancement after contrast injection. The classic location and no enhancement are diagnostic of a tuber cinerem hamartoma, which occurs commonly in boys more than girls and is usually associated with precocious puberty and sometimes seizures in these patients. Then the sagittal images are very good in this particular area, and you can see here, this is the site of the tuber cinerem. If you see a mass here, confirm first that it does not enhance with contrast, because this is typical for the tuber cinerem hamartoma. This is the pre-contrast, and this is the post-contrast, and the lesion does not enhance. This is typical for the tuber cinerem hamartoma. And you remember in the anatomy, I have said that there are two small lesions here with small structures which represent the mammillary bodies, and it's above the mammillary body you can see this lesion which is not enhancing here or there. And you see the sagittal images are very good for demonstration of the site of the lesion. And then you can diagnose it as a tuber cinerarium hamartia. Then we came to the biennial body tumors, and you have only 4. The 4 which are زي ما حضراتكم عارفين اللي هم المشهورين قوي، اللي هم الباينيوبلاستوما، باينيوسيتوما، باينيال تيراتوما and the باينيال جيرمينوما. ولكن الباينيال بودي باعتبار ان هو is a vascular lesion وموجود في حته انتراكرينيال معرض لاي حاجه، ممكن يطلع فيه سيلفيل سيست، وممكن يطلع فيه بايلوسيتيك استروسيتوما، وممكن يجي فيه ميتاستاسيس، ممكن يحصل فيه كل حاجه. لكن الحاجات اللي سبيسيفيك فور ذا باينيال بودي ريجن هم الاربعه دولت اللي هم every now and then you can see. اين يقع الباينيال بودي؟ in the quadrigeminal system. وبما ان الباينيال بودي بيكالسيفاي لوحده يبقى التيومرز اللي هتطلع منه في الغالب هتكون فيها كالسيوم. Then if you see a lesion like this in the quadrigeminal system which is homogeneous or heterogeneous enhancement containing calcium or not containing calcium, then you diagnose that this is a biennial body tumor. Then if anyone asks you which one of the 4, you cannot identify unless you have a specific criteria for the lesion. كأن التيراتوما containing fat. If the tumor containing fat, then you think of biennial teratoma. الجيرمينوما علشان تشخصها لازم يكون معاها واحدة تاني في السوبراسيلر اري، يعني ايه اللي بيسموها اكتوبيك باينيلوما. فلو لقيت 2 تقول ديت باينيال جيرمينوما، غير كده ما ينفعش. تلاقي lesion in the biennial body lesion and this lesion may represent any one of the biennial tumors including germinoma and including teratoma, but the fat is not apparent in the tumor. ولكن if the fat is well demonstrated, then you think of the teratoma. This tumor bienioblastoma after surgery, but here you see the tumor in the biennial body and in the region of the biennial body in the sagittal image. All what is needed from you is to say that this is a biennial body tumor and you describe the mass effect and the resultant hydrocephalus. Then, in order to diagnose biennial germinoma, there should be another germinoma in the suprasellar area. And you see 2 tumor masses, one in the biennial body and one in the suprasellar area. وبتعرف ان اللي في السوبراسيلر جيرمينوما عن طريق الباينيال بودي، وبتعرف ان اللي في الباينيال بودي جيرمينوما عن طريق اللي في السيل. لكن لو كانت الجيرمينوما لوحدها you cannot say that this is germinoma. في فرق وحرق كتير جدا في الكتب، والايدج ومش الايدج وده مش عارف كومنلي كالسيفاي ومش كومنلي كالسيفاي، كل دوت سفسطه ملهاش اي معنى خالص. لكن كل اللي عاوز الراجل منك الجراح انك انت بس تقول له ان this is a biennial body tumor، عشان وهو بيشتغل سواء بالمناظير او غيره يبقى عارف هو بيعمل ايه. Then if you see fat inside the lesion, then you may this is the MRI-T1 weighted image and the fat is bright. Then in cases you detect fat in the biennial body tumor, they think of biennial germinoma. And this is also the pre-contrast T1 weighted image, and there is a focus here which may represent fat or hemorrhage. Then if you have any technique for fat suppression and you can confirm the possibility of fat, or you have the CT scan, you can confirm the possibility of fat, then after enhancement, the lesion shows heterogeneous pattern of enhancement. Then the biennial germinoma is diagnosed by the presence of the biennial body tumor and another one in the suprasellar area, as I have said. And germinomas are أنواع كتيرة جدا، ولكن احنا ما نعرفش ولا واحد منهم بالأشعة زي الامبريونال سيل واليوك ساك والكوريوكارسينوما والتيراتوما. And we cannot say specifically the histology of any of them، ولكن ممكن نقول بس إن this is germinoma based on the presence of another tumor in the suprasellar area. Then this is biennial germinoma, and you see the 2 lesions in the axial image and the 2 lesions in the sagittal image. The sagittal طبعا أجدع بكتير من الأكسيال، ولكن الاثنين can see the lesion. And you remember the هوت اللي في السوبراسيلر اريا ده بيسموه the ectopic باينيلوما. ولو كان العيان عنده bilateral retinoblastoma وعنده bineal body tumor بيسموها the trilateral retinoblastoma. And this is bineal metastasis from cancer lung, and the tumor is not different من أي واحد من الأربعة اللي قبل كده، ولكن considering إن العيان عنده the primary malignancy, then you consider a possibility of metastasis. Then we came to the congenital tumors, and congenital tumors means that العيان أو المريض مولود بالتيومر دوت، وهم أربعة: ده جانجليوبلايوما and the net اللي هو this embryoplastic neuroectodermal tumor and the glioblastoma multiforme and the teratoma. Then starting by this embryoplastic epithelial tumor which is the net. This is a congenital tumor، يعني العيان أو المريض بيتولد بيه. واحنا في المحاضرة بتاعت النيورونال مايجريشن ديسوردرز هنناقش الجماعة دولت بالتفصيل، ولكن هم ليهم طريقة كده سهلة ومميزة، إن هم أصلا ما بيعتبروش تيومرز بالمعنى المفهوم، يعني ده بيعتبر مرحلة متوسطة ما بين الكورتيكال ديسبليزيا وما بين التيومر اللي هو حقيقي. وفي ال WHO بيكلاسيفاي it as grade 1. and this tumor عبارة عن تقدر تقول كده زي عنقود العنب، حاجة فيها سيستيك كومبوننت صغيرة قوي قوي قوي، كلها اوف CSF سيجنال، ولو حنتها صبغة ما يرضاش يتحقن، ما يرضاش ياخد صبغة. and this is the appearance in the CT, and the appearance of MRI بيبقى more or less أحسن بكتير. الحاجة الوحيدة اللي انت بتعرف بيها الجماعة دولت هو الكالفيريال سكالبنج، انك انت اول ما تلاقي التيومر جنب السكال تلاقيه عامل له حفرة كده جنب على السكال، لان التيومر دوت is present since birth، وعمال يكبر بالراحة قوي قوي قوي، وعمال ايه يرسم نفسه في جدار الجمجمة. This is the most في رأيي يعني the most diagnostic clue ان this is a congenital tumor، ان هو موجود في حد صغير قوي. and this patient is usually presenting by epilepsy. كل النيورونال migrations بتبريزنت by epilepsy، وتلاقيه عامل لنفسه حفرة كده في السكال اسمها calvarial remodeling. and this calvarial remodeling can be seen easily by MRI, however also can be identified by CT. Whenever you see this appearance, you consider it as a congenital tumor. If the tumor do not contain calcium and it appear exactly like the CSF or an infarction, then you think of this embryoplastic tumor. But if the tumor is containing calcium and may show contrast enhancement, then you think of this ganglioma. And this is an example, and you see the calvarial remodeling by the tumor, which is of low signal in the T1 and the high signal in the T2 weighted image. And if you inject contrast, the lesion will show some enhancement. Then, في بعض الأحيان, if you see that the tumor is surrounded by extensive perifocal brain edema, and you see this calvarial remodeling as well, and the cystic component is very large, you can assume that this has been turned malignant. And the malignant form of this tumor is known as anaplastic ganglioma. Then this is T1 and coronal and sagittal without contrast injection. And the tumor is, the main component of it is fat. And this is a congenital teratoma, which is seen in this pediatric age group, diagnosed by the presence of extensive fat inside the tumor. And sometimes you may get a baby with an intracranial tumor which show the features of glioblastoma multiforme, including heterogeneous pattern of contrast enhancement. Then glioblastoma multiforme can occur intrauterine and can occur after birth, which is considered now as the congenital intracranial tumor. Then the last two issues are the arachnoid cyst and the epidermoid cyst, and both are not considered neoplastic, but they are usually في كل الكتب بتاعت الأطفال they include them in the title of the pediatric tumors. Arachnoid cyst is classically located against the greater wing of the sphenoid. It shows a smooth border. It has the CSF content in the CT and MRI. It does not enhance and it does not show calcium. Then this is the classic appearance of the arachnoid cyst by MRI T1 weighted image and the T2 weighted image. And this is also the classic appearance of MRI in the T1 and T2 and the flare. And the flare images will show the CSF as black. Then if you see the cyst which is black, then you consider it arachnoid. But if the cyst is bright then or intermediate, then you think of epidermoid cyst. And this is also the arachnoid cyst in the T2 weighted image and in the flare and in the diffusion. In the diffusion weighted images, arachnoid cyst will show free diffusion, ولكن الإبيدرمويد cyst will show restricted diffusion. And this is the classic arachnoid cyst in the sylvian fissure. The sylvian fissure هو المقر الرئيسي بتاع الارachnoid cyst intracranially سواء في الأطفال أو في الكبار. Low signal in the T1 and high signal in the T2 weighted images. In the epidermoid cyst, المقر الرئيسي بتاعه هو the cerebellopontine angle. And it has a lobulated outline and it has a creeping nature. It does not show contrast enhancement but may contain calcium. Epidermoid cyst may contain calcium. And if you have the flare images, the epidermoid cyst will not appear black because it does not contain CSF but contains other fluid. Then this is the T1 with contrast and this is the T2 and this is the flare showing that the lesion is epidermoid cyst. Then this is the arachnoid cyst in the T1 weighted image, axial and coronal. And this is the flare of an arachnoid cyst and an epidermoid cyst. And this is the diffusion weighted image. The arachnoid cyst will show the free diffusion and the epidermoid cyst will show the restricted diffusion. Both lesions are almost similar in the T1 and the T2 weighted images, but the differentiation will depend on the flare images where the arachnoid cyst will appear black, similar to the CSF, but the epidermoid cyst will appear gray. And in the diffusion weighted images, the arachnoid cyst will appear free and the epidermoid cyst will show the restricted diffusion. And thank you very much.